Assalamu alaikum.
Waalaikumsalam.
How are you?
Alhamdulillah.
Good day, inshallah. Today our meeting about long cases. Okay, so we can start by al-Kitab. أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. So we need the first presenter, inshallah. Who will be the role player?
I will be the patient.
You will be the patient.
I will be the doctor.
Very
me,
good.
doctor.
Who is the patient? You?
Me. Yes.
Idlan.
Okay. Who is the doctor?
Me, doctor.
Okay. A good expression, because sometimes if you are dealing with our job and forgot that the role player can be changed, and sometimes the doctor became sick and they need a doctor, is very important. So always deal with the patient with complete respect and complete sympathy, please. It is it considers something reward from Allah if you are able to do that. Because any patient consider a weak point in his life. So if you support him, it is a good deed. Okay. I need another one to be controlling for the timing. About 20 to 25 minutes maximum for the history. Who will be the Uski?
Here.
Okay, that's fine. You are welcome, Nadia. So Nadia for Uski. Okay, let us go. I hope everyone can switch off the mic so we can concentrate only with our patient and our doctor. Okay. Thank you. Yalla, Bismillah.
Doctor, may I ask, do we need to conduct the session in English or in Bahasa?
It's for you. If you make it in Bahasa, we will.
Can I mix a little bit if there is something that I cannot apa recall?
I used to make it by English.
Okay, okay.
But if you need to do it by Malay, you are welcome. I try to. Okay.
Assalamualaikum, Mr. Idlan.
Salam.
May I ask, what macam mana nak kata? Why do you come here?
Oh, because my son,
Why?
my son Muhaimin come here because of, excuse me?
Huh?
Oh, my son come
Continue.
here emergency because of fever.
Because of fever,
Fever.
How long?
For 2 days, 3 days of fever.
3 days including today.
Yes. Today is third day of fever.
Macam mana distribution? Do you documented the temperature of the fever?
Oh no, I don't document it. But my son very when I touch it's very hot lah. And sometimes he also shivering.
Shivering.
That's why I come to hospital because worried about it. And then the fever on yesterday,
Huh?
I also noticed rash at his abdomen. So that's why I come today, because usually if my son fever, I only go to clinic. But because the rest come, I worried, so I come here. Because
So, hello? Terputus pula. Mana pesakit hilang? Sorry, doctor. Our patient lost connection. Hello?
hello.
Hello? Itulah.
Okay, sorry.
Let's
Okay.
continue.
Okay.
So, may I ask about the rashes on what day of fever that is developed? On
I think
first day,
yesterday,
second day,
I think second day of fever.
second day of fever is developed.
Yes.
Started at the bodily part At the
First
chest or
started at
abdomen?
the abdomen, and then
Abdomen.
and then I put some. I afraid because my son for pastly he also had eczema. So but this is like a typical lah, because it's start from the abdomen and then it's extend until the neck and chest
Oh,
until
it started at
today.
the abdomen
And extend
and
until chest and also neck for today.
for today, okay.
So that's why I came here.
Can you describe the rashes a little bit?
Rashes. I think
Is
it's
it
very rare. It's very rare.
benjo?
Mm, It's not.
Any papule?
It's just like a small like sandpaper, sand distribution like that around the abdomen, and then extend until the chest and neck.
Oh. No, can you apa kata ulang balik? Can you repeat what is the sandpaper? What is that?
It's look like kata apa, macam berpasir-pasir lah.
When you touch it? Or when you
Yes.
see it?
When touch it. And it's very red lah.
Oh.
It's like inside bag like that. I don't know.
Like inside bite. You mean it's a little bit elevated from the skin, the rashes?
I think so.
Wow. Did your child experience any itchiness?
A little bit itchiness,
A little bit itchiness,
but it's not much. Not like eczema before lah.
Not like eczema.
Not like eczema before.
Usually the eczema that your child has, usually at what part of the body?
Usually at hand, behind the ear.
Hand and behind the ear only.
Yes.
Okay. Other than fever and rashes? Sorry, I forgot to ask. Do you ever picit the rashes?
No.
No Apa lagi? Other than fever and rashes, did your children have any sore throat?
Actually, my children is very painful lah when want to eat. I don't know why.
Very painful when to eat
Yes. And lately, during this episode of fever, he did not want to eat much.
Why? Because of pain?
Yes, because of pain.
For how long he lost?
Start with the fever.
Start with the fever.
He had don't want to eat because of the pain.
Hmm. Don't want to eat. So, aduh, apa lagi?
He say
So-
it's very painful lah when it's
When
swallowing it.
eating,
Mm.
did your child have any runny nose?
No,
No runny nose eh?
no runny nose.
No. Only painful during eating eh? No cough,
No,
no cough.
just painful during eating.
Any abdominal pain?
No abdominal pain.
Any
Despite our
headache?
brush, there is no pain. Headache, no.
Oh, oh. May I ask, how old are your child? I forgot.
7 years old.
Oh, 7 years old.
Uh,
Oh. Complete vaccine eh?
yes, complete vaccine.
Complete vaccine. Have you noticed that in your living area there is any recent cases of dengue?
Yes, there was fogging also in this area.
So there is fogging also eh?
Lately lah. Then also I worried lah.
Hmm. So is there any of your family member that has same symptom with him?
No,
No.
but for sore throat, last week my nephew also have sore throat too, but it's already resolved lah. So, but my son share ice cream with him. Is it related?
Hmm. Wait.
Okay.
Masuk. Hmm. Apa lagi? 12 minit lagi. Sir, regarding the rashes,
Hmm.
wait, forget. Do you examine your child neck?
Just tak examine pun.
Or do you notice any lumps that around his neck area?
No, there was
No,
only the red rashes only surrounding the neck lah.
Do you look into his mouth?
No, I don't
No,
look to his mouth.
Oh. Macam mana? Oh, do your son has apa kata? Aduh, apa nama? Conjunctivitis? Conjunctivitis.
What is that?
Runny eye eh? Apa mata berair?
Dry eye? No any
Mata
no
berair.
any eye symptoms lah.
No any eye symptom eh? Don't know lah.
It could be eczema.
Not sure lah. On your son face, do he has any rashes?
Rashes? No. Only at the abdomen until the neck. No rashes at the face.
Any joint pain?
Joint pain? No.
Any abdominal pain? Kau aku dah tanya.
No abdomen.
No.
Ah.
Apa lagi? Sudah.
This is the first time episode, doctor. Before this, no like this presentation pun.
Any apa kata recent contact with sick people ke?
This time my nephew Nana.
Nana.
Hmm.
Any history of travel ke?
No. We stay at home.
PKP. Benda je. Do you do you realize any the face of your children becoming paler surrounding the mouth?
Pale? You mean look pale lah?
Look pale lah.
No. He did not look pale. It's only flashy, I think, because of the fever.
May I ask that you said that during the episode of the fever, he had reduced amount of oral intake, right?
Because of the sore throat, painful when swallowing.
May I know from usually he take how much, and after the fever he take how many?
Oh, usually he will eat like two bowl of rice lah when lunch, one bowl of rice when dinner. But this current
Dark diet lah.
Yes.
Okay.
But around this time he doesn't want to eat. Half a
At
bowl
all?
pun cannot finish.
For both for one day?
For lunch lah. For lunch, half bowl. For dinner, half bowl.
Oh, satu
When
bowl
I
lah.
make porridge pun also he did not take much.
Okay. Do you give any medication to him before?
I just give for the rashes. I just give Vaseline lotion because
Vaseline.
before this eczema, so I give Vaseline lotion.
Before the onset of the rashes, do you give your son any medication?
No.
Your son have allergy or not?
No.
No.
No allergy.
No allergy.
He can eat everything. Yeah.
Do you realize that your son become slightly lethargic?
During this episode, slightly lethargy lah.
Lethargy lah.
Because of the fever.
No wheezing, no night sweat?
No.
No. Itu apa benda je? Apa benda je? So, you said that this is the first episode
Yes.
Before this, do your son come to the hospital for any reason other than this episode?
Only clinic lah, because several time of having the doctor say eczema. That's only clinic.
You get the medication.
Yes.
And the eczema resolve like that.
Yes.
Do your child had chicken pox? Dah ada chicken pox?
Yes.
When?
I not remember. At age 5, I think.
Age 5.
During kindergarten.
Wow. Ada asma? Any asma?
No,
No,
no asthma.
any apa kata? Allergic rhinitis. Every morning sneezing.
No,
Or allergic to the dust, no eh?
no.
No. Apa benda je? Hmm. Hmm. So, ah, do you have any cerita nak tambah itu lain?
I think no.
Ish.
Maybe I just want to add like my family like me also have like eczema, also have asthma. My mother also have eczema and also eczema only lah.
Your
And this
mum?
is not my mom lah, my wife. Sorry, my wife. And this is my only child lah.
Only child lah.
Hmm.
7 tahun. You what age, sir?
30.
Asma? Asma. Your wife?
30 gak.
You have any asthma? No.
Yes.
Yes, got.
My wife je. My wife tak ada asma.
Oh silap. Okay lah, I ask about birth history lah. During your wife, okay, when he was in mother's stomach, do your mother compliant to the visit at the
My
clinic?
wife lah.
Your wife, your wife.
Yes.
Yes.
She never miss the checkup.
Never miss the checkup. Not taking any drugs or smoking.
No.
Problem during pregnancy.
No.
No, your wife do not have any apa kata diabetes during
No.
pregnancy, no hypertension
She's
like that.
healthy, no
Healthy,
diabetes, no hypertension.
So when he was born, is it cukup bulan? Is it full term or not?
Yes, full term.
Full term.
37,
38, 39,
38.
38. Do you remember the birth weight?
I think around 3 kilogram. I not remember well. 3 kilogram maybe. My wife might know.
Spontan or
Yes.
cut? Spontan.
Easily spontaneous.
Easily spontaneous. Wow. So after the birth, there was no complication.
No.
Like your child being admitted to the ICU, no
No. All very lancar lah.
Lancar, no demam-demam kuning jaundice
Only a way of jaundice and then that's it.
That's it. Resolved by itself Okay. So for the do you remember for how long your son was breastfed?
Breastfed. I think until 2 years.
2 years lama. Start apa eating bobo?
6 months.
6 months. Using tak apalah. So do you remember at what age that your son started his adult diet?
Adult diet.
Don't remember
No. I think 6 months start to eat netto, everything.
Estoma. Currently toilet training ke?
Yes.
Masih Allah. Developmental, tak ingat. Tak tahu.
Basically, for development, he okay lah. For now, he can play football very well, climbing. Also can follow the teacher's instruction, can count, can spell, can write his own name.
Time's out lah.
Okay.
Remaining 1 minute. 1 minute only.
1 minute.
Yes.
Wait. For his asthma, asthma pula. For eczema, what medication that he take? Only ointment.
Ointment.
Ointment. What name?
Don't remember Vaseline lah.
Celine, ya. Okay. Ada any taking supplement or not?
No.
No, eh?
Mm-mm.
Okay. You, sir, forgot to ask. You work as what?
Oh, I work as teacher.
Your wife?
Nurse.
Yes. You living at where?
Live at where Kuantan.
Yelah, more specific.
Taman apa lah? Indra
Hisap
Mahkota.
Indra Mahkota. Aku tak tahu.
Okay, Hadidi.
Yes, doctor.
Yes, you need to summarize now.
Only summary, doctor.
Yes, in a short time, please.
Okay. So, doctor, for this patient, Encik Muhaimin, Adik Muhaimin, a 7 years old Malay boy, was presented with the was presented to the hospital for the complaint of fever for 3 days and rashes for 2 days prior to admission. So the rashes, it said that was distributed around the body, extended towards the neck and also the chest, and felt like the coarse sandpaper. So the rashes, I forgot to ask. About any discoloration of the lips and also the tongue.
Okay.
So, apa nak kata lagi? So, other than fever and rashes, is also associated with the loss of appetite since the onset of the fever. And it said that the loss of appetite is due to the pain experienced during the eating. He said that his father said that the patient also lived at the dengue prone area by the evidence of the fogging event at his housing area. Okay. Macam mana nak kata je? Other than that, the patient also had a history of contact with the sick people 1 week prior to the event with his nephew, his cousin. Apa lagi? otherwise, doctor, he had a strong history of the apa kata of the atopy with his father is the asthmatic and
Raise your voice.
dah mute ke? Dah mute ni. Sorry doctor, I did not realize the mic is mute.
Okay,
Sorry.
raise your voice, please. Okay.
So, this patient, Adik Mohaimin, a 7 years old Malay boy, was come to the hospital with the complaint of fever for 3 days and also rashes for 2 days prior to admission. So the fever, however, is not documented the temperature. However, it is associated with chills and rigor. For the rashes, the father said that the rashes was started at the abdominal part and extended to the neck and also to the chest area. So the rashes was described as red and felt like coarse sandpaper upon touch. So other than that, the patient also experienced loss of appetite due to the due to the pain, due to the experiencing pain during eating. And apa lagi? The patient also has strong family history of atopy uh, whereby his father is asthmatic patient and he had eczema. So the patient also already had a chicken pox at the age of 5, 2 years ago. And other than that, the patient do not have any runny nose, URTI symptom during this episode other than painful during eating. Mute lagi ke? Tak eh? Okay.
What is your working diagnosis then?
So like for current history taking, due to the history of, oh, I forgot to mention history of sick contact 1 week prior to the episode of the fever. So for the current, sorry doctor, I forgot to mention again that the patient also living at the dengue prone area whereby his father said there is a few evidence of the fogging around the housing area. So
You mentioned it before.
Oh, mention eh?
Yes. So what is your diagnosis now? And what is your differential diagnosis?
So currently for my diagnosis, the first one is the scarlet fever because the patient had experienced the fever for 3 days and he had a sick contact with URTI patient 1 week prior to this episode. So the patient also had rashes that developed on the days 2 after the fever, whereby it spread from the abdomen to the upper part of the body. So, and I think the most, which I can say the pathognomonic feature of the scarlet fever is the, the rashes is felt like the coarse sandpaper during the touching.
Okay. What is your differential diagnosis?
So for my differential diagnosis, my differential diagnosis. Maybe the patient had Henoch-Schüsslein purpura or Kawasaki disease, because these two has a little bit similar pathophysiology, where only the differences is the size of the vessel that involved. Apa lagi ya? Other than Kawasaki and also HSP, maybe rubella is one of my provisional diagnosis, because the rashes appear on the second day of the fever also. My least differential diagnosis is chickenpox and eczema.
So he can go to chickenpox for the next time, for second time?
No, not likely. Why, doctor?
Other differential diagnosis.
Ada differential diagnosis, maybe the measles and apa lagi?
So how can
Oh,
you
itu.
confirm your diagnosis now? What investigation you will consider?
So for the scarlet fever, to confirm the scarlet fever, we need to do the throat or nasal swab to find any any focal infection of the Streptococcus in this patient, particularly in the throat. And at the same time, if the patient already had sore throat for a long time, maybe we can do the anti-streptolysin O titer in order to know to confirm there is a recent infection of the Streptococcus in this patient that lead to the scarlet fever. Hello, menunjuk ke?
Okay, for Kawasaki disease, what investigation you will consider?
For the Kawasaki disease, since Kawasaki disease is considered as autoimmune, I would like to do the inflammatory marker, which is the ESR and CRP, to look for any inflammation of the vessel itself. And from what I read, there is two Kawasaki disease biomarker that can be done to detect the events of the Kawasaki disease, which is the Meprin A, doctor.
Is it available in the market?
No, not available yet.
So what you will do? What you will investigate?
Lagi.
Okay. Why this patient is not dengue?
Oh, dengue. Oh, this patient is not dengue.
Can be?
It can be also, doctor.
Okay. So how can you diagnose HSB?
To diagnose HSP, same like the scarlet fever, we need the throat swab and also the the throat swab and ASOT.
What is
And
HSB?
what, doctor?
What is the HSB?
HSP is the Henoch-Schüsslein purpura. It is
Okay.
the autoimmune disease that affect the small vessel.
So you need to do the same like scarlet fever?
Same like scarlet fever plus Kawasaki disease. We need to do the throat swab, SOT, plus inflammatory marker.
Henoch-line berbera.
Uh,
What investigation you will consider for any berbera?
Coagulation profile.
Coagulation profile. What else?
Full blood count.
Looking for what?
Full blood count looking for thrombocytopenia.
Okay, what is the definition of thrombocytopenia?
Thrombocytopenia is the platelet count is less than 150 over. Oh, I forgot the unit, doctor.
How can we say mild or moderate or severe?
Based on the platelet count.
Okay, so what is mild, moderate, and severe?
I forgot that.
Okay. So another important diagnosis you must remember nowadays. What other important diagnosis? Patient came to you with fever and the other respiratory infection.
COVID, doctor.
It is not smiling. If you didn't remember it, you must cry. It is very urgent now. Any case of fever or ILI, influenza-like illness, you must consider COVID. Otherwise, you will not take your precaution, your enough personal protective equipment, and you may infect yourself and infect others. And it is not you alone. It is an important community issue now. It is international now, epidemic. So any fever, you must say, my rule is to rule out is COVID. Okay. Don't forget, COVID sometimes in the children presented like Henoch-line berbera. Many cases presented as HSB and proved to be COVID. Many cases diagnosed looks like dengue and at the end came as COVID. So you asked about the job of the mother and the mother. What is the job of them?
The father is the teacher. The mother, I forgot lah.
Nurse.
Apa?
Nurse.
Oh, nurse. Oh, nurse.
Is it important?
Yes, doctor. Nurse. High risk occupation.
Did you ask them about traveling history?
Yes, I already asked, but he said only stay at home.
Only stay at home.
Ah.
But his mother is stay at home or she is working?
Oh, I
Is
do
what-
not ask about that.
Is it important?
Yes, doctor.
Okay, okay. So can we see the OSCE, please?
Can you say it? Okay, this is the first question.
Can you increase the volume, please?
Increase the volume.
Yes.
Can you hear me?
Yes, good.
Yes. Yes.
Okay. So who's wanna answer the first question? Any volunteer? Should I pick? Okay, let's start with Rahel. Can you answer the first question, please?
Okay, so the picture shows inflamed tongue,
Hmm?
probably because of Kawasaki disease.
Yeah, and then?
Scarlet fever as well.
Okay.
And the DDX can be dengue fever as well because of inflamed mucosa.
Yes, that is it's a picture of strawberry tongue, which is the effect of vasculitis and also inflammation of the mucosa. And among the differential you can think of is Kawasaki disease, scarlet fever, and also toxic shock syndrome. So basically toxic shock syndrome is kind of complication of the fever itself. So I think dengue can be considered, but less likely lah. Okay. Okay. So we move on. Next. Can I have Shahira, please? Can Shahira hear me?
Yeah.
Hello?
Hello.
Hello?
Hello.
Can you hear us?
Hello. Okay. So, dengar ke?
Dengar, dengar.
Okay. So basically, this lesion is island of White, the Sea of Red.
Okay.
So diagnosis dengue fever. So which phase? I think. Is it on febrile phase?
You sure?
I think it's on recovery phase.
Yes, it is on recovery phase. Can you explain about the phase if you can? How many phase in dengue fever?
Basically, dengue fever has three phases. Febrile phase, critical phase, and recovery phase.
Okay.
So usually for the febrile phase, is it three? Okay, so usually for the febrile phase, you have 3 to 7 days of fever. And then for the critical phase, 1 to 2 days, and for the recovery phase, 3 to 5 days.
Is there anything we need to watch out in any of the phase?
Warning sign, which is
The crumple.
Yeah.
Yeah.
Okay.
Teruskan.
So yeah, the crample pneumonia. So first we have clinical fluid accumulation, which is ascites, and then R we have yeah.
Yeah, we can listen. We can hear you. Go on. Interrupted. Hello? Oh, I think we just lost her.
So who can answer which phase it need more attention?
The critical phase, doctor. So in dengue, we have febrile phase, critical phase, and also recovery phase. And the phase that we need to take can take cautious is in the critical phase, which is the 24 to 48 hours after the fever subside. Because this is the time we need to monitor the hematocrit, also the platelet, because this is where they can become deteriorated, causing thrombocytopenia and cause bleeding. Dengue hemorrhagic fever can occur at this time.
Yes, please. Dengue fever, no matter to miss any knowledge about, because it is one of the most common disease. Even when COVID became less, dengue started to increase. So we don't have any excuse to know from A to Z. Please, no excuse to know from A to Z for dengue and the other communicable disease. Okay. Okay. Thank you. Next slide.
Okay, next slide. Can I give this to Idlan? Can you describe this picture, please? What can you see? Or should I enlarge the picture?
Oh, hello.
Hello? Okay.
Okay. So,
Sorry.
so describe this picture. This is basically a child with I can see at the eye have upwards slanting eyes and also flattened nose and face. And we also cannot appreciate the nasolabial fold. That's like at the cheek, I think it's like flashy red. So my diagnosis would be Down syndrome.
Yes, this is a picture of the Down syndrome baby. We can see the flat nasal bridge, upslanted eye, also loss of nasolabial fold. And then they have what I want to say. Apart from the faces, what else can we find in a Down syndrome baby? Is there anything you want to add? On the hand, maybe?
Maybe at the hand can be single palmar crest, and also there will be short fifth finger.
Short fifth finger, okay. Also, we can also add in the sole, there will be what separate of the first wax. So basically this is a Down syndrome baby. Okay, move on. This one, Zahir?
Sorry, come back to Down syndrome.
Zahir, betul.
So what is this rash in the face?
Flushing.
Yeah, in both cheeks.
Sorry, what?
What is the rash in his face?
What is the rash?
Yeah.
Is it malaria?
Is it eczema?
I'm not sure, Prof.
Okay.
Okay. Next,
Okay. Next slide, okay?
Abi?
So describe the finding in this photograph. There is thin extremities. So we can see there is grossly ascites, as evidenced by the it is grossly ascites. So what is the nutritional status of this child? I think she is malnourished due to protein deficiency. What are the cause of abdominal distension in this child? Maybe due to protein deficiency, so reduce in albumin level in the blood, so they will have ascites. And what are the life-threatening emergency associated with this condition?
What condition? What do you think this patient these children have? I mean, what diagnosis came to your mind? So from that diagnosis, what is the emergency you can think of?
So I think this patient has kwashiorkor disease, and the life-threatening emergency that could arise due to maybe death due to malnourished, deficient in protein.
Other than protein, what can you think of? Other metabolic that can cause emergency?
Other than that,
Hypo of anything?
sure. I'm not sure.
Actually, this picture is it's about just generalized wasting, and then there's ascites you can see, and actually this is a picture of marasmus kids, children with marasmus. So the emergency that can come is hypoglycemia, hypokalemia, and also hypothermia. Okay.
Okay.
I would like to ask you why you said he has ascites.
Because we can see grossly distended abdomen.
So it is ascites. How
But
can
we
we
have to confirm with.
Yes. With what?
Pardon?
How can you diagnose ascites?
We can do physical examination by eliciting the fluid trill and shifting dullness.
So please don't hurry to diagnose, because we know that distended abdomen is 5F, as you got it before. We cannot say it is fluid or non-fluid until we do our examination. That's why it has grossly distended abdomen. I suspect it can be ascites, but also I must rule out blah, 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 blah. Okay? There is an important thing happen with this malnutrition known as refeeding syndrome. You start to refeed him rapidly, he can get a lot of complication. Okay. Okay, can we see the next one, please? Next slide. But try to make it related to our case today. Okay.
Okay. I think the next one is related, so can Haziq take it?
So I can see the injected sclera here. Hello? Okay.
No.
So I can see the injected sclera here. So maybe the patient had conjunctivitis.
Okay, is there any addition? From the picture, there's another features that can bring you to diagnosis actually. True, it's conjunctivitis. True. But there's a unique features of it if you look closely. Okay.
Differential for conjunctivitis. Allergic conjunctivitis. Measles. Kawasaki disease, EHSP,
Most likely?
like most likely. I'm not sure.
Actually, this is a picture of, it's true it's conjunctivitis, but to be more specific, this is non-purulent limbal sparring conjunctivitis, which is a kind of most likely to Kawasaki disease. Non-purulent limbal sparring. Can you see the limbal is still white, it's not injected. Kan nampak?
Yes.
This one. It's not injected, right? So this is limbal sparring in Kawasaki disease. Okay. Next one. Siapa lagi dulu? Ain. Ain.
Yes.
Okay. Name the test and explain the result. From the result, what is the diagnosis?
This is test for meningitis, for symptom of meningitis. One is the top one is the clinic sign, I think, which is happen when you straighten the leg and hip flex to 90 degrees will cause stiffness of the hamstring.
Okay.
And then the down one is the Busikin sign, in which when you flex the necks, it cause also the hips and knees to flex also.
Okay.
So here is for
Sorry, I think we need to got about 10 to 15 minutes now to pray al-Maghrib, as al-Isha is soon. Okay? Let us finish pray and restart again.
Okay.
Assalamu alaikum.
Okay,
Waalaikumsalam.
Left
Entah.
Untuk beat je lah.
Video je.
Okay.
Assalamu alaikum.
Waalaikumsalam.
Waalaikumsalam, Doktor.
So can we continue our OSCE? Okay. Who will answer?
Nadia, mute.
Sorry. Okay, Shazwani?
I think this is the suppurative tonsillitis, whereby you can see the tonsil enlargement, and also there is a multiple pus entered on the tonsil. So the grading could be grade 3 suppurative tonsillitis. Other differential diagnosis could be tonsillar abscess.
What else?
Can be Kawasaki HSP.
Why?
Boleh ke? No, doctor.
If you don't know, said I don't know.
I don't know, doctor.
Okay, there is one virus can cause like this.
COVID.
Who can answer? A famous virus. Infectious mononucleosis. Epstein-Barr virus, EBV. Sometimes it can cause follicle and has also lymph nodes. And you must be able to put it in your differential diagnosis, especially if you got another criteria for Epstein-Barr virus. Another important differential diagnosis also. Very important. If you got history from this patient and he told you we are anti-vaccine family, and you found it unilateral and it is bigger size, not only patches like that, like looks like membrane. Who can answer? Anti-vaccine family, and you got something like a membrane.
Oh, diphtheria, doctor.
Sorry?
Diphtheria.
Diphtheria. That is the importance of getting a detailed history of the patients. We mustn't forget any part from our history which we recommend to be achieved, please. It happened in some area on the world that got diphtheria, okay, and the patient presented like that, and some doctor just prescribed antibiotic, and then he came with carditis and entered to the ICU. It is very dangerous, okay? And also to say kissing the tonsils Stage 4, we can diagnose it, no need to diagnose on resting. Usually if we said and it can touch, it is enough to say it is stage 4. Otherwise, if we need it to be kissing a tonsil while he is comfortable, he will die. There is no way to breathe from the mouth, okay? Another important point, how to differential diagnosis between viral and bacterial tonsillitis. Anyone knows the name of the criteria? Okay, please go ahead for Google and read how can we differentiate between viral and bacterial pneumonia, bacterial tonsillitis, please. Second slide, please. Next.
Ain, please. Zurain can.
Hello? Hello?
Yes.
This is post-surgery on abdomen, on chest. Most likely a congenital heart disease.
Genital
Seems to
heart.
be a left horizontal scar or wound.
Okay, who can help?
Condition. Maybe PDA.
Yeah, this big.
Any other candidate can try to add some knowledge?
Shazwani, is there anything you want to add?
This child could have undergone coarctation repair. Also PDA ligation.
So, okay.
So this is true. This is a left lateral horizontal scar. Usually, children with congenital heart disease, if they undergone surgery, such as in PDA ligation, like Shazwani said, and also the coarctation of aorta repair, as well as is there any ballot shunt. Can Ilan tell me when does children got blood Thomas shunt?
Sorry, I don't know.
Anyone?
This is an important point, please, because scar, as I told your colleague before, skin is a very good entrance to the body. Any skin rash, any skin manifestation, like yesterday we are speaking about one patient with convulsion, and then we find some cafe au lait spot like that. We are going to speak about 9 types of neurocutaneous syndrome. Also, if you found any scar in the body, you must comment number 1, is it fresh or old and healed? How long is it? Where is it? Why it is here? Does it signify anything? And the last one, is there any other scars? Because many of this you will find another microscopic even scars like drainage, like microscopic opening. And at the end, is there any complication of the scar or not? Don't be hurry in the exam, or if you see any patient, you must go ahead and measure. It looks like 6 centimeter, fresh scar, not yet completely healed, with some redundant skin. It is present in the transverse in the abdomen, going to the lateral side, directed to the back. Even if you cannot, you will suggest, okay, this can be, it is not splenectomy, of course. It is not in the area of nephrectomy. It doesn't look the child has some trauma or like that. So it can be something deep going to the heart like that. Okay. So at the time, if you are going systematically, you can get, if you didn't get the final diagnosis, you will be near to it. Not so far. Okay. Do you need to add anything, Nadia?
Regarding the Dr. Sichan, basically it's a surgery for pathology of fellow.
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 Okay.
Pathology of fellow.
Okay, thank you. Next slide, because we have another case. We need to go through it.
There's another 2 questions, but it will be shared by Rahil. So I'll stop here. Can Rahil proceed with another 2?
Can everyone see my slide? So may I have Evelyn to answer this?
Describe the lesion. I think this is the features of coffee outlet. So my diagnosis will be neurofibromatosis.
Which one is the cafe au lait?
Which one? The arrow.
Oh, so what is the others? Yes. What is this?
There is nodular lesion and then multiple nodular lesion.
What does it mean?
I'm not sure.
You just said it is.
Neurofibromatosis.
Yes, this is the neurofibroma. Okay. If you are correct, because we need some criteria for cafe au lait to say it is neurofibromatosis regarding it the number and the size and the age of the child. Okay, but if you find the neurofibromatosis, it is on itself, it is one of the like gold standard for diagnosis. Okay, other signs?
Other sign of neurofibromatosis would be maybe bone defects can result to scoliosis and also optic nerve lesion.
It is neurofibromatosis type 2. Okay. Any comment from the presenter?
Okay, so yes, it is true that this is a coffee outlet lesion with multiple nodular lesion, and then the diagnosis is neurofibromatosis. So the other signs that can be presented in this case is axillary or inguinal crackling, like crackles, right? And also bowing of legs, like the legs will look like bow. And then other than that, there will be loose nodules on the eye, and also what else? I think that's all. Anyone else add?
Okay, you can go through the diagnostic criteria and don't forget the wood lamp. Wood lamp is as a type of light, which if you put in the back, it will looks like ash leaf here. It is very diagnostic by dermatologists. They can diagnose it very easily. Okay. At the same time, the presence of cafe au lait make it more clear. It need bigger size because when I saw it the first time, I said, "Is it molluscum?" Molluscum contagiosum, but it is not so umbilicated. It is only the light is in the center. Okay, thank you. Next slide.
Okay, next slide. A child came with rash around ankle and buttock, also complaint of joint pain. What is the diagnosis? Nadia? Nadia, you're mute.
If the child have rash and ankle and buttock, complaint of arthralgia, I think of Henox-Slate purpura, HSP.
Okay.
Because among the common area for HSP is at the buttock, also as at the extensor surface, and leg, arm is also at the ankle. As well as arthralgia is also symptoms of HSP. So,
Okay, thank you. Then I would like to just give a simple comment, please. Again, during the time of pandemic, don't forget the cause of that, like COVID, and don't forget that there is overlap between the test of COVID and the dengue. Some cases diagnosed by combo test like dengue, and when we did COVID, it will come positive. Most important, if you found any rash, you must do meningeal sign because some meningococcal meningitis can cause rash, which is blanching. And please try to divide the rash into type, blanching or non-blanching from the start, because it is completely different. Either going to go ill or going to the other direction. If you missed it, is very dangerous. You must comment, is it blanching? It looks like viral rash, or non-blanching, so it is purpura, and they are going to completely other direction. Okay, this an important point. Remember that the most dangerous enemy to us in the medical field is the time. How can we assign our timing? Sometimes you are given a good time for a long case to stay with the patient for looks like 1 hour, and you still chat without intention for to come to the diagnosis, and find yourself you didn't examine the child, didn't put enough, didn't arrange your mind how you are presenting yourself. So please try to take time, take notice about the time. Also, anyone who is working in the medical field, we must suspect health associated condition or transmission, please. I think we can now shift to the next case. And I would like to take your opinion. Should we start after that at 8? Can be? at 8 p.m., not at 7. We just finish in Maghrib and then we can start after that. So we can start from 8 to 10, inshallah. Is it okay? Can just inform the other group, especially for our seminar. And I hope if the next seminar, I think I have seminar with you in the next week. There is new timetable today.
Seminar will be at week 4 and week 5, Doctor.
For me, no seminar this next week.
Next week, no.
PDS.
Next week. PPS
Next
week
week,
4.
no seminar with you.
Yeah.
There is
Dr. Chan and Dr. Azam.
Just a while, I think there is some details. You are year 5, yes? Year 5?
Yes, year 5.
Timetable. Seminar, this is seminar timetable year 5. Suppose Monday. Okay, yes. It is only a case. Thank you, good. So let us start by the second presenter, who will be the group. And I hope they can handle the time efficacy, please.
So next will be me and Shazwani.
Okay.
My name is Abir Burhanuddin.
Abir and Shazwani is what? Who is the patient? Who is the doctor?
I am the doctor and Shazwani is the patient.
And who is presenting the non-OSCE?
Non-OSCE.
OSCE.
You? Who will present the OSCE?
Me.
You. Okay. Okay, let us start, please. Take notice about the time, please. Okay. 20 minutes. And then presentation, and then OSCE. Okay. Bismillah.
Bismillah.
Okay.
So can you introduce yourself, Mama? The mom. The mother.
My name is Rose. I'm a 37-year-old mother.
Okay, where do you live?
I live in Kampung Kurnia.
Okay. So what's your daughter's name and her age?
My daughter's name is Iman Kasih.
So I can call I can call her Iman. Okay.
Yes.
So what for today, what are your concerns that makes you come to the hospital?
Because I noticed my daughter had fitting at home, so I was worried. I am worried. That's why I bring her to hospital.
So she was fitting now.
Yes, fitting.
any video that you record the fitting episode?
No, I forgot to record the video.
Yeah. So can you elaborate to me more about the fitting episode? When does it occurs?
So
And what?
I noticed the fitting episode when she is sleeping. So during sleep, suddenly she had a sudden fitting. But I think there is no triggering factor that make her to fit at that time.
So during sleeping.
Yes, during sleep.
Is it around what time did your child sleep?
After going back to school when she sleep, and then around 1 p.m.
Okay. So during the fitting episode, can you describe more about the fitting? Is there any abnormal posture or abnormal movement?
Yes. Yes. Initially, I noticed that my daughter had developed the eye will be at the eye gaze move to the left, and then but at that time my daughter is still responsive. But after that, suddenly I noticed there is a jerky movement, jerky and stiffness on both of her limbs, upper limbs and also lower limbs.
Can you demonstrate what the jerky upper limb?
The jerky, like it's contracted.
Contracted. Okay, so
it's contracted. All the hand and legs are all contracted.
contracted. Okay, is there any drooling of saliva or tongue biting?
Yes, I noticed there is drooling of saliva, and also I noticed that her lips is smacking, and also during the episode of the fitting, my daughter passed.
Ashwin. Did you notice any fecal matter to the clothes or
There is no fecal matter.
okay, is there any bluish discoloration of the lips that
No.
you notice? No.
No bluish discolorations of lips.
So during the fitting episode, did you try to call her names or wake her up?
Yes, but during the fitting episode, he had loss of he actually unconscious.
Unconscious. So what did you do when your child is fitting?
So when my child is fitting, I try to, because before this my child already had been diagnosed with epilepsy. So the doctor teach me some technique when my child during to handle my child during fitting. So I try to position her first at left lateral positions, and only I can time the how long that the fitting episode occur.
So previously so this is not the first time of not the first episode of seizure lah. This
Yes,
is multiple.
this is
recurrent. So during the previous episode of fitting, does the abnormal movement occurs the same in the characteristic of fitting? Is it the same as current episode or different?
Yes, it is same like this current presentation.
So may I know when was your child diagnosed with epilepsy?
So my child was diagnosed with epilepsy when she was 4 years old. And then the presentation was similar to these episodes. And by that time, she need to be intubated and admitted to pediatric ICU because yeah, fitting lasted more than 1 hour. From what I remember.
What you remember? Okay. When was the last episode of the fitting?
Last episode was 1 month ago with similar presentation.
Is there any medication that that being prescribed by the doctor and any regular follow up for the epilepsy?
Yes. My daughter was on syrup sodium valproate and also syrup lamotrigine. And also she was under follow up at pediatric clinic, HDA 3 monthly.
So I would like to ask regarding before the fitting episode, did your daughter complain any aura, anything that is weird happening to her, like seeing flash of light, any
No.
headache?
No headache,
No. Yeah.
no trauma.
Trauma.
Ah.
When was the last meal before the sleep?
During lunch hour.
So around
12. Around 12
12
p.m. and then she sleep.
around 12 p.m. So 1 hour prior to the fitting was the last meal lah. Okay,
Yes.
then after the fitting episode, did the child respond to your, I mean, did the child responsive after fitting? No. When was for how long the fitting lasted?
I think about 40 minutes because I just call ambulance to come to bring her to the emergency department hospital, and then at that time the fitting persistently going on, and even in the ambulance also. So upon arrival at emergency department, and also some medication was given to her, and then the fitting stopped. So about 40 minutes.
40 minutes. In the ambulance, is there any medication given?
Yes.
Yes.
The ambulance and hospital, yes. Through and also injection.
Through NS and injection.
NS.
Okay. Did your child has any fever before the?
No, there is no fever.
No fever. No fever, no trauma.
Yes.
So any nausea or vomiting?
No nausea and vomiting also.
Any neck stiffness or rashes on the skin that you notice?
No.
No. Okay.
Okay.
So for the regarding the epilepsy, is there any family history of epilepsy in your family or your husband family?
No, there no family history of epilepsy or any seizure.
Any family history of rashes or macam skin lesion that your family has, like macam birthmark ke?
I'm not sure about that.
Okay. Apart from epilepsy, did your child have any other medical illness?
Yes. My child have at day 15 of life, she had been diagnosed with congenital heart disease, and the doctor say the name is TAPVR, and surgical operation was done.
Operation was done. At
Hmm.
that, so at that time, your child is there any symptom before being diagnosed having the congenital heart disease? Any symptoms?
Yes, because I noticed there is bluish discolorations of her skins and also her lips. That's why I'm worried. And then
Okay. Apart from that, any other medical illness?
no medical illness, but my child also had development delay in her development.
Oh, delay in development. So, can you recall when was your daughter able to walk independently? Can you recall?
No,
At what
no,
age?
I can't recall because it's too long time to recall.
So, currently, she is studying in
She is studying in Sekolah SK Kampung Bukar. She is in pendidikan khas class.
pendidikan khas.
Because of her problem.
Okay. Okay, so now I would like to ask during the problem during the pregnancy, is there any illness that the mother has during pregnancy? During
No,
the pregnancy? No.
no illness, and I am very healthy.
So around the pregnancy, so the Iman was born via normal or operation?
Operation Caesar
At term of
at term
why Caesar?
because the position is in breech position.
Oh, because so at term lah, at term, and do you remember the birth weight of your child?
Her birth weight during is 2.8 kilogram.
0.8. So after giving birth, is there any complication to the mother or to the child?
Mother no, me myself no, but my child had jaundice on day 3 of her life, and she was admitted for a week and requiring phototherapy due to jaundice.
For how long the jaundice last?
1 week.
1 week. Okay. During so did you breastfeed your child?
Yes, but only for 3 days. But after that, I give formula milk.
So after that, you give formula milk lah.
Yes.
After then, can you recall at what age that she weaning?
At
Normal diet.
2 years old.
2
2
years
years old.
Okay. For the vaccination, did your child completed vaccination up to her age?
Yes. Complete.
Complete
According
lah.
to her
So
age.
any extra vaccination apart from the scheduled vaccination?
No. No side effects.
side effect. Okay. Then I would like to ask regarding your husband. So your husband currently what age? How old is your husband?
My husband, I think 40 years old.
You think 40 years old?
Yes, because I'm not living with him already. I'm already divorced.
So you didn't know about the occupation where did he live right now?
No, I don't know.
So currently you are living with your child lah.
Yes.
With only your child. So
Yes.
Iman, how many siblings does Iman have?
6 siblings, and she is the youngest out of 6 siblings.
So the other sibling is healthy, or is there any illness that they have?
Healthy.
Healthy.
Yes.
So you work as what is your occupation?
I work as a house cleaner.
Can I know about your monthly income?
About 800 ringgit monthly.
500. Okay. So just now you said that you live at Kampung Kurnia. So what's the did your house far away or near the? Is there any nearest clinic or hospital? Clinic near house.
No.
So the nearest was this hospital lah.
Yes.
Usually it takes how many minutes to arrive to the hospital?
About 40 minutes to 1 hour.
Minutes to 1 hour. Okay.
Okay.
Done. Dah.
Development.
Development. Okay. So regarding I would like to ask currently did your child can speak fluently and can form a full sentence?
No. She was not able to speak fluently, and she only can speak in phrases.
No, currently able to speak in phrases only lah. Did she able to write, to read or write?
No.
No.
Now still unable to read and write, and that's why she was being put in the pendidikan khas class.
Okay, regarding self-care, did your child eat and groom herself dependently or need any assistance?
She need help from me myself.
Okay.
That's all. Have you proceed summary? Proceed summary. Doctor, we have done with our case.
Can you make summary? I believe I would like to inform you that ability to make summary is one of important professional job for any doctor. I mean, it will be short time you will be in duty whenever you are in a ward in emergency department, and you have a lot of patient at the end of your heavy duty, and you need to endorse it to the coming staff. If you
Yes.
didn't train yourself how to present the most important points with the most important details, and there is some other details can be not so significant at the time. Otherwise, you will do endorsement until the end of the next shift. Okay, so this is the importance of try to help yourself every time to make summary and can try to make it shorter as you can. Okay, but it carries the same weight of knowledge which can guide the audience for you what it could be. Let's try with Abir.
Yes. So my patient, Iman Kasih, a 7 years old Malay girl with underlying epilepsy, diagnosed at 4 years old, currently on medication and follow-up at PITS Clinic at IUMC, presented with fitting episode for about 40 minutes. So she developed the fitting episode during sleeping. Otherwise there was no history of trauma to the head. There was no fever, rashes, neck stiffness, and headache to suggest meningitis. There is no vomiting or diarrhea to suggest electrolyte imbalance. And there was no history of vomiting to suggest any space occupying lesion. So my provisional diagnosis current now is status epilepticus. Status epilepticus secondary to epilepsy. Secondary to epilepsy. Because the points for is the fitting episode lasted for more than 30 for about 40 minutes, which is more than 30 minutes, that we can diagnose status epilepticus. And then another point is that she has underlying epilepsy and she had been diagnosed with epilepsy, currently on medication and follow-up. And the third point is there is no triggering factors, mean that the fitting episode is unprovoked. Okay. For my differential diagnosis, first one is meningitis. So why it is not meningitis? Because she has no fever, neck stiffness, any headache, or any behavioral changes before. Okay. Number two, my second provisional would be space occupying lesion. So, however, in this case, she did not has any signs, symptoms of the raised ICP like projectile vomiting. Okay, and the third one is metabolic cause, such as hypoglycemia or hyponatremia. However, the patient last meal was 1 hour prior to the fitting episode, in which I assume she did not has hypoglycemic episode. And there was also no history of vomiting or diarrhea to suggest hyponatremia. And the fourth one is trauma. However, there was no history of trauma. And the last one is tak ada. That's all, Doctor. That's all for my provisional and differential.
Okay, so let us make it more simple. So this a patient or a known case of epilepsy presented by breakthrough convulsion in a form of status epilepticus. Yes. The most common cause we must rule out is
First is the cause of breakthrough seizures.
the most important cause at this scenario, which we must rule out. You said meningitis. I agree, but there is one thing used to see it more: breakthrough fits.
Breakthrough.
So, what is the treatment for her?
So the treatment for her, in the ambulance, she was given
No, the original treatment of epilepsy.
the original treatment by giving anti-epileptic drug such as
Dr. Abir, I'm asking you what's your patient given for his epilepsy? Did you ask?
yes. The mother said that it was lamotrigine and sodium valproate.
Did you ask it about the dose?
I don't know
The dose.
the dose. I didn't ask.
Did you ask
But
how
the
many
dose.
times per day?
No.
Did you ask any investigation requested for this medication?
So I didn't ask.
Yes. It's our job now. If the patient said whatever he is given, we must ask about the name, the dosage, any precaution, is there any enough supply for it or not? Because one of the most common cause is
Non-compliant to medication.
yes, very, very important. We are not attacking our colleague, but it happens. Sometimes maybe uncompliance came from us. We are not giving the patient enough time to build her mind that this case needs to be continuous in treatment. She is not allowed to stop it at all until the doctor take the decision. And every time we are insisting it will be in regular time. And if the patient vomited it, he must get another dose. And sometimes asking her for standby extra bottle in her bag. Sometimes she is traveling like that, she will forget the treatment and search everywhere who can give her anti-epileptic, she cannot find. So it is very important the communication with the family. And this is another job of the doctor. The doctor is not just a doctor, he has a very important social role. And every patient you are making a good communication with him, you are doing your job professionally and you are near to Allah if you did your job like that. So you must make sure that your patient have all details and have precaution. You must take care about that and compliance, because sometimes maybe the patient has a compliance, but I need to consider one important test, which is serum level. I may need to ask about the serum level. It may be she is not given the optimal dose for the drug. That's why. But most of the cases of status epilepticus, make sure that the patient given already the medication with the same dose, he doesn't vomit it or omit some doses. Otherwise, we are going to ask for another, like he got infection, like meningitis or other causes of, okay? This is the top important, please, with us. So our history, once I came to conclusion, now I'm speaking to a case of rash. I'm discussing now a case of epilepsy with breakthrough convulsion. So I must come for a few seconds and ask myself, what is the top priority? Haziq before speak to us about berberic or non-berberic. Now we must ask compliance or non-compliance. Is it CNS infection or not CNS infection? Is it metabolic? What other causes? Is there any new thing happen, like trauma, like child abuse, like whatever. So I must build my brain. And this one, it will be cumulative. You will see today one patient who is uncompliant, one patient who is a congenital anomaly, which is very difficult to be managed already. So now, what is the definition of status epilepticus?
Yes. Uh, the seizure are lasting for more than 30 minutes and more than 5 minutes is for impending status. Seizure
35. Which is
seizure for
which?
more than 5 minutes we call impending status epilepticus. So more than 5 to 30 minutes is established status epilepticus.
Who can complete the definition? Is fitting more than 30 minutes or?
From Sunflower Group, it says that a seizure lasting 30 minutes or repeated seizures for 30 minutes without recovery of consciousness. Without recovery of consciousness.
Raise your voice, please. Let us hear. Increase the volume.
Status epilepticus is a seizure lasting 30 minutes or repeated seizures for 30 minutes without recovery of consciousness.
Okay, this is very important. It is not a must to have continuous convulsion for the 30 minutes, but it may be the patient got the fit and he doesn't regain consciousness and got another fit. At the time, we are considering it as a status epilepticus. Okay, that's why in any case of convulsion, we must concentrate on what happened before the convulsion, what happens during the convulsion, and what happened after the convulsion. Is there any aura? What is the type of the convulsion? We must know what is the type. Is it focal or generalized, or focal then progress to generalized, or it is absent like that? And after that, what happens after the patient already stopped convulsion? He got any neurological deficits or not? So it is very important to go the history and to go deep for that. The first point which your colleague speak about, if the patient came to the history convulsing for 5 minutes, I will assume that he has status epilepticus and I will start the protocol. And we have a very, very nice protocol how to handle the status epilepticus. Just open your protocol, you will find a lot of table. Really, it is very worthy to remember it in your mind. That of asthma, that of epilepsy, like that. So at the time, if he came to you within 5 minutes, not suppressed, you must go ahead for the table, start by the first line, whatever, if the ZBAM or are going to watch the second time, what you consider now, because now the Kibra now appear in the, to be more effective. So a lot of neurologists are using now Kibra as a second line. Okay, that is my issue. So this is the definition of status epilepticus. But generally, if I ask any one of you, what is the causes of convulsion? Generally, whatever it is, short or prolonged, who can answer?
The cause of convulsion.
Okay.
You mean the cause? First, the epilepsy can cause convulsion.
Okay.
Then any space occupying lesion also can cause convulsion.
Increase of what?
And any
Increase.
infection, increase
Okay.
in ICT. And then due to infection such as meningitis or encephalitis or any sepsis also can cause convulsion. Like, then any autoimmune condition like SLE, and then brain abscess,
Okay.
any metabolite imbalance such as hypoglycemia, hyponatremia.
What else we used to see? Any increase in the intracranial pressure, like
uh, space condition, brain abscess,
space occupying lesion, malignancy or not, can cause. And there is one important point which can cause convulsion also, related to like hypertensive.
hypertensive encephalopathy.
Yes, in a severe hypertension, because sometimes we are forgotten that many cases of post-streptococcal glomerulonephritis or whatever the cause of glomerulonephritis presented by hypertension, but it is very severe, so it is hypertensive encephalopathy. Now it causes irritation of the brain, and the patient came with convulsion, and we are running to do the table of status epilepticus, but unfortunately, if we concentrate in the blood pressure, we will know that it is hypertensive emergency. That's why medicine, we must be very wise regarding what can be the differential diagnosis, what can be the other causes. And you must ask yourself, don't accept single diagnosis. I know we must come to establish diagnosis, but while we are thinking, we must put other differential diagnosis for every patient. Okay. So you speak to your colleague now, speak to me about meningitis and encephalitis. Who can differentiate between both? I need a new face.